put myself on. Welcome everyone. While we're waiting, if you could go ahead and introduce yourself in the chat, that would be great. That way we can see who's joining us. And also, just to let everyone know, this webinar is being translated into French. So if you follow the instructions here, so if you click on the interpretation globe symbol at the bottom of your Zoom screen, that should open up the option for French interpretation. And you just have to make sure to leave, to then click mute original audio. And then you should be able to access the French translation of this webinar. Okay. All right, well, should we, why don't we go ahead and get started? And if others can introduce themselves via chat, that would be great. That way we have a sense of who's joining us today. Oh, sorry, I'm getting messages that my audio is not great.
Is that better for sound?
Can you talk a little bit more, Neerja?
Okay, hopefully that's a little bit better. Welcome everyone. Please go ahead and introduce yourself in the chat. Thank you for those who've started to do that. And why don't we go ahead and get started? If we could go to the next slide. Oh, could we flip to the, oh, thank you. So this webinar is a collaboration between the Choice and HP Plus projects. And as you will know, across this series of webinars, we have been covering different topics. So we have covered implementation planning, developing PrEP guidelines. In our last session, we covered topics around demand creation for oral PrEP. And today we're coming back to the beginning to really talk about these two sections that will help inform planning and budgeting and supply chain management. And we'll be covering 3 topics today. So if we can go ahead to the next slide. We will be really talking through how to use the PrEP tool. PrEP is a tool that can support target setting, costing and budgeting, and commodity forecasting for PrEP. So we will have our speakers going through each of these 3 topics, and then after each session, we will pause for Q&A. So please, this is meant to be a learning session. Please add your questions into the chat, and we will make sure that either our panelists answer them either verbally or in the chat itself. Next slide, please. And our 3 speakers today will be Catherine Kripke from Avenir Health, Joseph Marungu from PSAT in Zimbabwe, and Chris Obermeyer from USAID in DC. Next slide, please. And just a reminder before our panelists get underway and take us along, a reminder that there is French translation for this webinar. You can access it by looking at the bottom of your screen where it says interpretation with the globe icon. If you click on that, you can click on the French translation, and then you just also have to click mute original audio to mute the English version. Otherwise, you'll be hearing both at once. And with that, we can go ahead and get started. And I will pass it on to Catherine Kripke from Avenir to provide a brief overview of the session and of the PrEP tool.
Thanks, Neerja. Good morning, good afternoon, everyone. This is Catherine Kripke from Avenir Health on the Choice and Promise projects. And Today, we're going to be talking about target setting, costing, and commodity quantification using PrEP. And I think everyone knows that these are all very important parts of planning for PrEP. So I think that's why you've joined. And before we get into the specific topics, I just wanted to give you a brief overview of the tool itself. Next slide, please. Can you advance the slide? Thank you. So PrEP stands for PrEP Implementation, Planning, Monitoring, and Evaluation Tool. And it was funded by USAID through the Health Policy Plus Options and ETAP2 projects. And this webinar is actually co-sponsored by Health Policy Plus. And it's currently an Excel-based decision-making and analysis tool. And it contains 6 interrelated modules, including tracking the cascade of PrEP initiation, the capacity assessment and efficiency analysis, target setting, which we'll be discussing today, costing, which we'll be discussing today, estimating the impact of PrEP, ARV forecasting, and actually a new module that's not shown here for geographic prioritization for PrEP for adolescent girls and young women. And let's go to the next slide, please. So we generally think of this as having 2 different types of users. So on the one hand, we have governments and donors who will primarily be using it for program planning. And on the other hand, we have PrEP implementers who will be using it primarily for implementation M&E. Of course, both types of users can use any of the functions of the tool depending on their needs. And users can focus on whichever aspects of the tool or whichever modules are needed at any given time. So you don't need to use all of the modules, just whatever you're trying to do. So we're anticipating that the planners will be using the tool to set targets, project costs, look at coverage and impact, track progress. And the implementers will also be using the tool to potentially project costs and track progress, but they may also be using it for assessing the capacity to deliver services, identifying efficiencies in the initiation cascade, and project client flow and ARV needs. Next slide. So PrEP and a lot of supporting materials, including a user guide and YouTube videos about how to use the tool, can be found on PrEP Watch at this URL. And we hope that you will use it. And one more slide. So we're really excited to announce that we're in the process of developing an online version of PrEP version 2.0. And that will have an improved user interface as well as additional functionality. So we'll be able to plan not only for oral PrEP, but also incorporate what we're calling a method mix of PrEP. So different methods of delivering PrEP, oral, ring, injectable, etc. And you'll be able to plan for all of those as part of your combination prevention package. And in addition, the tool will be able to compare and compile results across subnational geographic units, which we weren't able to do in the 2-dimensional Microsoft Excel version. So we're very excited about that and looking forward to having people using it in 2021. So I'm going to hand it back over to Nirja to introduce our first speaker.
Thank you, Catherine. I will be passing it along to Joseph Marungu from PSAT in Zimbabwe. He will be sharing how to use the PrEP tool for target setting, as well as his experience using it in Zimbabwe. Joseph, on to you.
Thank you, Niraja, for the introduction. Good morning and good afternoon, everyone. I'm happy to be here to share our experiences from Zimbabwe in terms of using the PrEP tool. We can move to the next slide. Thank you. Yeah, so in terms of target setting, there are 2 main purposes. The first one is centered around planning and budgeting, where we are looking at making sure that we have adequate resources to support the targets that we intend to achieve in terms of funding commitments, the medicines, the staff, lab, and other resources required to support PrEP implementation. But we're also setting targets as a way of making sure that at the end of the day, we also estimate the epidemiological impact on HIV incidence across the different population groups that we will be targeting. Next slide, please. So based on these two purposes, there are two common approaches that are used. There's the top-down approach, which depends mainly on coverage. So we define PrEP coverage as the number of people initiated on PrEP of the total number of people who are at risk, among which PrEP is indicated. So with this top-down approach, targets are set based on the desired priority population coverage levels. The second approach is based on capacity, and it tends to be a bottom-up approach where targets are set based on capacity for PrEP delivery. So this factors in human resource capacity, supply chain capacity, strategic information, and other components of the health system. Next slide, please. So when you when setting targets, there are a number of challenges that you are likely to come across. The first one is centered around identifying the populations that should be prioritized for PrEP, and actually knowing the size of those priority population groups. Here in Zimbabwe, we had challenges, for example, in terms of the size estimates for men who have sex with other men. We did have size estimates for female sex workers. And from the census, we had estimates also about for adolescent girls and young women. So to address this, we had to depend on regional estimates and extrapolate also some of the assumptions for us to have estimate population sizes. The third challenge is centered around knowing the percentage of each priority population group that is indicated for PrEP. I'll talk a bit more about this one later on. And then there are also challenges around estimating continuation rates. So you really have to learn from similar projects within the region or in country to inform the estimated continuation rates. And then the other challenge is centered around cycling on and off PrEP at varying periods of risk. And then the last one, which is important, is understanding what targets are feasible given the funds and other resources that are available against the demand. Next slide, please. In terms of the inputs for the PrEP tool, there are a number of inputs that can be considered depending on the approach and the specific needs. And nearly all the input pages can actually be used, but whichever method you end up adopting, the three highlighted ones should always be used. So you need to define your priority population group. You need to specify continuation rates and then generate the targets. Here in Zimbabwe, because we are focusing more, we're using the coverage approach highlighted earlier. We didn't use the options around estimating capacity or specifying costs and estimating impact to inform the targets. But you can also make use of these other options. Next slide, please. So this is just summarizing the same steps that I highlighted previously that you need to go through. So I'm going to talk about each of these steps as you use the tool in the next few slides. Next slide, please. All right. So you need to complete the populations that you prioritize. There are some specified populations in the tool, but then the good thing is there's also room for you to enter in additional custom populations depending on the local context. So you might want to add long distance drivers, you might want to add miners, artisanal miners, fishermen, or any other population groups that are a priority in your local context. So this is the first and very important step, because it then informs all the other subsequent steps that you go through as you set your targets. So you need to check the specific priority population groups that you'll be targeting. Next slide, please. And then understanding continuation is a critical component of the tool. And continuation data is needed for 4 points in time. You can also modify this based on your local context. For example, here in Zimbabwe, our guidelines say you see the client at month 1 and then 3 monthly thereafter. So what it means is we see our clients at month 1, month 4, month 7, month 11, and so forth. So you can also adapt this to your local context to come up with the continuation curve. And then there are 3 options for entering the continuation curves in the tool. The first one is an already calculated from country M&E systems. The second one, you calculate continuation rates based on a sample of individual client records using the continuation calculator. And then the third option is based on other studies or programs with similar features from within the country or within the regions. Next slide, please. And then the next step is then to complete the continuation tab. So you then enter the continuation rates based on the program or existing program data or aspirational continuation or other similar studies for each of the months highlighted in the next slide, please. And then the next step is to capture initiations in the initiation tab. So if available, you enter the monthly initiations from the past 2 years in order to account for PrEP delivery for continuing clients. So as an example here, we capture the data for initiations among serodiscordant couples, female sex workers, and men who have sex with men. And in this case, we included both initiations and reinitiations, but you can always select an option that best applies to your context. Next slide, please. And then the next step is to capture the population data on the targets tab. So optional national default data are provided for the pre-specified populations based on various data sources, including demographic and health surveys, as well as UNAIDS and other sources available online. And then for the percentage HIV negative at high risk, the tool also provides the most recent DHS estimates on a number of variables. So this is where I was highlighting earlier on that you might have challenges in terms of estimating the proportion of the targeted population that is at risk and is indicated for PrEP. So here in Zimbabwe, we had to review a number of variables, mostly from the demographic and health survey and programmatic data, looking at the STI symptoms, adolescent girls and young women reporting multiple partners and not consistently using condoms, and a number of other variables, so that we get the estimate percentage of adolescent girls and young women at risk and indicated for PrEP. Next slide, please. In terms of the scale up of patterns, you are then supposed to determine which scale up pattern you want to adopt. And there are three options. The first one is a constant approach. So this is where you are just aiming to initiate the same number of clients on PrEP every month. So as an example, you might decide to initiate 100 clients every month. So that's the constant approach. Then the linear approach assumes a steady increase in initiations each month, which means you may want to initiate 100 in month one, then 200 in month two, you get to 300 in month three, and so forth. The one that we used here in Zimbabwe is the S-shaped approach, which assumes a gradual start, because our national implementation plan adopted a phased approach. So you want to start at a small scale where you are learning as you go. You are also putting systems in place until you can then rapidly scale up and until you get to a plateau. So this is the approach that we used here in Zimbabwe, and we are currently in the rapid acceleration phase. Next slide, please. Right, and the next step will then include selecting the approach that you want to adopt. I've already talked about option 1 and 2, which are based on coverage and capacity respectively. You can also use a manual approach in which you enter previously determined numerical targets to review coverage and capacity. So those are the three options that you can then consider. Next slide, please. All right, so some outputs are related to the targets. So you want to define the populations. You can also specify costs, generate the targets, and estimate impact. And this is what you can also then get out of the tool. Next slide, please. Yeah. So just to close off, I just wanted to emphasize on, on a few critical aspects to the process of setting national targets. The first and most important one is to ensure that you engage all the relevant stakeholders. And so you need your technical and implementing partners, you need your funders in there, you also need civil society and community representatives, including potential beneficiaries. So here in Zimbabwe, we're working through the National PrEP Technical Working Group. And in this technical working group, we also included potential beneficiaries as representatives of adolescent girls and young women, female sex workers, and men who have sex with other men. We also had our major funding partners, including PEFA and the Global Fund, as well as the technical partners as part of this process. You then want to make sure that everyone is on the same page in terms of the process, but also the data requirements and assumptions that are used to inform the target setting process. You also want them to make sure that there is validation of the inputs from the various stakeholders as you draft the targets. Once you have your initial draft outputs, it is also critical to make sure that they are shared widely and you actually get feedback from the stakeholders. And you can then use that feedback to refine and finalize the targets. And then after that, you need to make sure that the targets are widely disseminated. So here in Zimbabwe, of and above the technical working group that I mentioned earlier on, we also have a national HIV prevention partnership forum where various stakeholders that are involved in HIV prevention, care and treatment and support services found, and this is a platform which we used to disseminate the targets that we developed. Once that is done, you then want to make sure that support is provided to facilitate implementation, and you have systems in place to monitor progress towards the set targets at national and subnational level. So this process shouldn't be hurried. You need to take your time to make sure that people understand the process and contribute to the process as well. And for us, it took us a couple of weeks to get the targets that then informed our COP20 plans, as well as the Global Fund concept note, which was submitted earlier this year. So just to emphasize again, it shouldn't be a hurried process. And you need the validation processes in place as well. Next slide, please. Just to acknowledge the various partners and colleagues who contributed to this presentation. Thank you very much.
Sorry about that, I was on mute. Thank you, Joseph. Does anyone have any questions for Joseph? I know one question that came through is, what if, you mentioned that there were a number of default settings or default values in the PrEP. What happens if you don't want to use the default values? And Catherine, maybe you can respond to that question.
Yeah, you can actually edit any of the values. So you don't need to use the default values. They're just there for your reference to get you started. But if you have locally specific information that you think is better, then you can definitely use that for any of the values that are provided.
Great, thanks, Catherine. And I know we also have Rigeru on from our colleagues at LVCT Health. And Rigeru, if you're able to speak, maybe you could also quickly share thoughts on the experience of using PrEP in Kenya.
Hello, everyone. So thank you, Niraja, for the question and the opportunity to briefly share on our experience in Kenya with PrEP. So a lot of parallels and similarities with Zimbabwe, in that with regard to the technical considerations with our use of the tool, we also opted to go for the coverage approach. And furthermore, worth mentioning in terms of the capabilities of the tool is that in Kenya, our HIV burden is concentrated in a number of counties that are classified as high burden counties out of, so those are a handful out of the 47 counties. And what you find is when you generate targets where you're focusing on particularly those high burden counties as opposed to all counties, it does create interesting variations that have programmatic implications. I think what's probably worth sharing the most with people considering use of PrEP was touched on, which is the stakeholder involvement being absolutely crucial, because ideally the use of PrEP would be something that is embedded within the national government as part of national target setting processes. And of course, to achieve that requires buy-in across the entire staff of the relevant departments. So that requires a lot of sensitization. It requires time to get the buy-in, and then there needs to be consideration, particularly if you're in a context of a decentralized health system as we have in Kenya, where county governments are then responsible for now planning their own PrEP service programs. There needs to be plans on how then what is done at the national level with regard to target setting and use of PrEP is then cascaded down to a county level. So that also requires capacity building at that level. There's also the need that our experience with government has often been, particularly when it comes to taking it down to county level and even lower, for the tool to be simplified as much as possible. And what you find that implies is that the tool in itself is simple enough to use, but there are the various considerations and data inputs that have to go in. And it's therefore more realistic to sort of have those already established at a national and county level, so that by the time you're now reaching the lower levels of the health system, it's more a question of explaining those inputs and then just sort of getting minor alterations depending on the local context, as opposed to taking everyone through and the entire scope of the tool, which can be overwhelming. Thank you, and over.
Thank you, Rugeru. And if there are no further questions, we will move forward with the next presentation. But please feel free to continue adding questions to the chat, and we will pick them up in the next Q&A session. So Catherine, I will pass it on to you to take us through how to use the tool for costing and budgeting.
Great, thanks, Nirja. Let's go ahead to the next slide. So before I start talking about the tool, I just wanted to introduce a few concepts to make sure that we're all on the same page. So oftentimes we say the word costing, but we might mean one of two different things. So on the one hand, costing can mean deriving the unit cost of providing service. And this is done by gathering spending and other data from implementation. This is done for the purpose of conducting cost effectiveness analyses and also for planning. And then on the other hand, we can say we're doing a costing exercise, and we might mean that we're determining the total cost of implementation, usually based on targets. And this can be done for the purpose of advocacy. So you want the full cost needed to reach some aspirational targets, regardless of where the money is coming from. Or it can be done for budgeting, in which case the costs need to take into account the actual targets, as well as which costs are being borne by whom in which year. The good news is that PrEP can actually assist with all of these. Next slide. So just another concept that I wanted to introduce is the idea of cost categories. So costs can be divided into different categories, such as personnel, and that could include medical providers, receptionists, community outreach workers. It can also, another category that's commonly used is commodities. So this might include your PrEP ARVs, or in the case of the ring itself. It could include lab tests, other commodities like gloves, syringes, whatever is needed. Another cost category is the capital costs, and that might include things like equipment, building space, vehicles. And then you have overhead costs, which can include things like site level training, security, utilities. Then there are also above site costs, so program management, national level training, national or regional mass media campaigns. So when we're working with the tool, we're thinking about the costs in terms of these cost categories. Let's go to the next slide. So another concept that I wanted to introduce was the concept of variable versus fixed costs. So with variable cost, the cost depends on the number of visits or the number of people served. So examples would be your commodities, your ARVs, your lab tests. And then there are fixed costs where the total cost does not depend on the number of visits or people served. And so examples of that might be program management or national mass media campaigns. And sometimes things fall in between variable and fixed, depending on how you're thinking about them. Let's go to the next slide. So I think you're going to see this slide a lot during the course of this webinar, but so for the purpose of specifying costs, you need to define your populations. You need to specify your continuation rate if you're going to incorporate that into your costs. And then the rest of the modules are optional and they all connect with the cost module. So you might want to look at cost effectiveness, in which case you would want to estimate the impact, and you might want to know the cost of the program that you've already implemented, in which case you'd want to enter your initiations. So all of these kind of link together. And if you want to cost your whole program, you would probably want to go through the target setting process that Joseph described, and then link your costs to your targets. So depending on what you want to do, you'll use different functions of the tool, like we mentioned before. Next slide. So what do you get for going through all of this? Well, you could get things like the unit cost of PrEP per person for a full year, or per person initiated, taking the continuation rates into account. You could get the costs associated with the targets that you've set. You could get the cost per HIV infection averted by priority population. Those are just some examples. Next slide. So the PrEP cost analysis was supported by the ETAP2 project, and it was led by Lori Bollinger, who's here to answer any questions that you have about the cost modules during the Q&A. And so one of the distinguishing features of costing using PrEP is that the costs are distinguished by visit type, so your initiation visit and your continuation visit. And it can also account for different continuation rates, which can be specified by different priority populations. So I'll talk in the next slide about why this is important. But just going back to the overview of the costs, there are two different cost modules within PrEP. So there's cost Lite, which is simplified, and there's detailed costs for more comprehensive cost analyses. And we're providing a lot of information about default values for costs, but then as we mentioned during the previous Q&A, all the default values can be overridden by the user, and you can put in your own specific cost information if you have it. Next slide. So why is it important to cost by visit? I think anyone who has implemented PrEP knows that continuation is an issue. You can't assume that's because somebody has initiated PrEP that they're necessarily going to come back for the next visit. And so in the kind of early days of PrEP implementation, when countries were forecasting, for example, their ARV needs, they assumed that people would continue on PrEP for a year or maybe for 6 months, and they estimated their costs accordingly. But if you take your continuation rates into account, then you can actually get better estimates of your cost based on the actual number of visits that you can project. Next slide. So as I mentioned, there are two different versions of the cost module. The detailed costs allows for specification of what we're calling service delivery modes. And what all really that means is any way that costs could vary. So that could be implementation models, it could be different parts of the country, really anything. And then it has more detail in terms of the labs and different types of visits. On the other hand, Cost Lite, if you don't want to get into that level of detail or you don't have that level of detailed information about costs, it's really just allowing you to provide different costs for different priority populations using a lot of default information that's available and fewer cost categories that need to be specified. Next slide.
Marriage. You know, the booking gate, you leave them everywhere.
So for the cost categories, in the detailed costs, we have the service delivery strategies. We have pre-initiation costs, so we include the cost of the HIV testing, PrEP screening and counseling. In both of the modules, we have cost by visit, as well as monthly costs, fixed costs, and above site costs. And then in Cost Lite, there's just cost by priority population. You have the monthly ARV costs, and then cost by initiation and continuation visits according to the cost categories that are listed here. So next slide. We've collected cost data from PrEP costing studies that were conducted in 6 countries and analyzed that to provide default costs as well as reference costs from all of these studies. So we got information about the staff time that's required for different types of visits, for different populations, and for different implementation approaches like fixed and mobile sites. So really kind of a compendium of a lot of cost information is within the cost reference information in the tool. Next slide. So for Cost Lite, your process is really going to be fairly simple. The first thing that you do is specify your visit schedule. So remember, we're costing by visit, so you need to say when are people coming in, and that might be different for different populations. If it's not, then you only need to specify one visit schedule. But we were told that, for example, in some countries, the adolescent girls and young women come in every month, whereas the other populations after initiation only come in every 3 months. So depending on how it's working, you have the ability to specify different schedules for different populations. And then you're going to enter your costs by cost category for each population. And then from that, based on which other modules you've completed, you can get your costs associated with targets, your costs associated with your actual service delivery, your cost per HIV infection averted, and some information about how improvements in program efficiency, such as better continuation rates, might affect your program costs or your cost per infection averted. Next slide. With the detailed costs, you have a lot more steps. So you're going to be looking at the cost for each personnel type and reviewing that and modifying that based on your local data. You're going to have the option to define different service delivery strategies. Like we mentioned before, that's just any way that cost might vary. And you specify your visit and your lab schedules, and then you allocate those for across the different service delivery strategies. And then you enter your cost data by visit types and by your cost categories, so your ARVs, your above site costs, other, etc. And then again, from this, you can get the costs associated with targets, the costs associated with service delivery, et cetera. They're really the same outputs, but just with a lot more detail. So next slide. Yeah. Again, this is the team that put the tool together, and we're looking forward to having some questions and discussion.
Thank you, Catherine. Any questions for Catherine? You can either add them in the chat or just unmute yourself and ask them to the group.
No questions. Everybody understood everything perfectly. One thing that I wanted to mention is, you know, as we were planning this webinar, we were thinking, should we showcase ways that different countries have done costing? And I said, no, we should really just show them how to do costing in PrEP because we think that it's actually the best way of doing costing, and other experience that was done before PrEP was available is really not as advanced as what we can make available through PrEP. So we're hoping that countries will use this. We hope that we've made it easy. It may seem overwhelming, but I think once you start looking at it, especially the cost Lite module, it's not really that hard. I wonder if, you know, Ruggiero has some experience with the costs in Kenya. I wonder if he wants to mention anything about the country experience using this tool.
Thank you, Catherine. I think what I'd want to mention with our experience in Kenya, and again, it speaks to what was shared from the Zimbabwe experience about making it involving as many relevant stakeholders as possible, is that we involved Chai in the work that we've done. So people with specific knowledge around costing in the process. And as Catherine said, Cost Lite is definitely the most accessible way for governments to engage with this particular feature of PrEP. And the key consideration is around the visit schedule, which is straightforward to establish in our context in Kenya, as it's clearly laid out in the guidelines. And I think moving on from there, as Catherine had said, it just provides a solid foundation on which governments can sort of make that transition around decision making about being more locally owned in terms of local funding for PrEP. Thank you.
And Ruggiero, I don't know if you even were part of the process at this point, but I remember early in the days when Kenya was planning its PrEP program, there was a request for the technical working group subgroup on costing to cost their plan, and we didn't have this tool available for them yet. So they had to create their own methodology for costing the plan, which was difficult, but now we have this available. So we hope that, you know, when they want to do the next iteration, that they'll use it.
Well noted. Yeah, I wasn't personally involved at that point in time, but I think the individuals who were now called upon when we've begun to engage the government with regards to PrEP.
And I wonder if, Lori, did you have any?
Oh,
Sorry, you just, either my computer just froze or you just froze. This is Lori. Did you want me to say something? Is that what you were asking?
Yeah, I was just asking if you had any comments you wanted to share.
Well, I think the only thing I would say is that Cost Lite is definitely more accessible and more usable. But if you are an economist and you really want to get into the details, the detailed costs module is really nice. So certainly Cost Lite is functional and it's kind of more user friendly, but there is that capacity to do a very thorough costing job using detailed costs. So let me just put in a plug for us economists out there.
Yeah, and actually, I don't think she's on the call today, but the lead for Chai and Eswatini used the detailed cost module to do an analysis of the cost savings from having a different laboratory testing strategy. So they were thinking, because so many people don't come back for their first continuation visit, that they would actually do the creatinine testing at the first visit instead of the initiation visit, and that they could save some money. So she used the detailed cost module to show the cost savings that could be incorporated by changing the laboratory schedule.
Nice.
Wonderful. Well, with that, maybe we can move on to the next and final presentation for today. So I will pass it on to Chris from USAID to take us through how to use the tool for commodity forecasting and quantification.
Hi, thank you. So I'm Chris Obermeyer. I'm a HIV biomedical prevention advisor at USAID, and I want to start by thanking Masai and Megan, who helped to put this together and helped do a lot of this work. So on the next slide, I'll just outline where we're going to be talking about. So I'm just going to give you a bit of background on PrEP in Ghana. I'm going to talk through how we used PrEP to forecast the need of ARVs for PrEP in Ghana, and then talk about how we combined the need for ARVs for PrEP with ARV stock levels for treatment in order to make sure that Ghana was prepared and able to launch PrEP. And then we'll end with some questions. On the next slide. So PrEP implementation in Ghana was expected to begin in RAP19 or COP19, which is the time period starting from October 2019 and ending in September 2020. Ghana uses TDF-FTC and TDF-3TC, both as components of their current HIV treatment regimens. TE and TL are both potential options for PrEP in alignment with WHO and the national guidelines for PrEP in Ghana. On the next slide. So the challenge that came up was that as a country new to PrEP implementation, there was really no indication or idea for how long people would be on PrEP once they started. There were some rumors that there might be people who would stay on PrEP for as long as 13 months. And that seemed to be something that was thought to be more as the expectation. And so the fears of PrEP implementation on ARV levels was valid. And so there was concerns that by starting PrEP or by starting it earlier, that it might cause shortages of TE and TL for HIV treatment. The next slide. And so in order to get some of the inputs that we needed for PrEP-It, we reached out to our field colleagues and partners to ask them a number of questions because we needed some inputs in order to use PrEP-It. So first we wanted to understand what might the estimated continuation rate be for 1 month, 3 month, 6 month, and 12 months. And so for a number of countries starting PrEP for the first time, they don't have this data available in country. And so we asked the countries and field teams, what do they think the estimated continuation rate would be for each population? We looked at some programmatic data from other countries in West Africa and tried to estimate based on contextual factors whether we thought it would be higher or lower in certain populations based on the results of neighboring countries and programs. Then we needed to know what we thought that the scale-up trend would be. So based on a number of programmatic experiences in West Africa, we started looking at how many clients they needed to anticipate in order to meet targets, and then the number of sites that they plan to provide PrEP at for key populations and for other populations. We also asked if there was any ideas about the demand. Some countries, when starting PrEP, may create almost like a waiting list so that they have a list of people to contact who are already interested and already asking for PrEP. And so we wanted to get some of that information from the teams as well. And then we also wanted to talk about if there were any other limiting factors that might prevent the scale up of PrEP. And then we also looked at the targets, which for PEPFAR were 1,418 in COP20. And then the targets for the Global Fund as well. On the next slide, I'm just going to start to walk you through the different pages and different tabs of PrEP. And so on the first slide, or on this slide, what we've done is we have selected at the bottom of the slide, we have selected that we wanted to forecast the number of drugs needed based on targets and based on service delivery data. On the next slide, we decided to create a custom group and putting the populations that we were going to focus on for PrEP and Ghana into one group, given time constraints and a lack of kind of background data about each of these populations. We decided that putting them together as a custom group, which is a great feature, would allow us to get the information compiled more quickly. On the next slide, you can see where we have put in our estimated continuation rates. And so we used a combination of programmatic data from surrounding countries, as well as published study data in order to estimate what our continuation rates would be. We lean towards estimating it a little bit higher so that we can make sure that we would have adequate supplies of ARVs. Based on this, you can see that we have assigned this continuation curve to the population that we are focusing on. And on the next slide, you can see the resulting continuation curve in blue. On the next slide, we needed to input any monthly initiations. Seeing that PrEP was going to be introduced in Ghana for the first time, we put in that the first year program data was September 2020, and the most recent was September 2020, and our initiation numbers were 0 because no one was currently on PrEP. On the next slide, we needed to enter our target setting period. So at the top, we put our target setting period was October 2020 and September 2021. On the next slide, we needed to set up our trend line. And so we selected a trend line with a midpoint of 6 months. So halfway between the year. We chose this because we felt that demand at the beginning may not be high and that we would expect to see an S-shaped curve. And I'll show a visual in just a moment of the different curve options. And then just below, sort of toward the middle of the slide, you can see that we have assigned that trend line to our population group. On the next slide, I have shown just a variety of the the scale-up trends that might be expected. So the line that we expected in Ghana was more like this blue line, though you can see what a constant trend line would look like, as well as a consistent trend line would look like. On the next slide, we have selected PrEP offers a number of options for setting targets. And so we selected option 3 because we had already set our targets for the year. And so there we have put in our target value of 1,418 because in this example, we were only looking at PEPFAR funded targets. On the next slide, we have moved to the results by month dashboard. And on the far right, you can see that we have used the number of initiations and currently on PrEP as proxies to help us to estimate the number of bottles of ARVs that were necessary. So on the next slide, you can see that table a bit better. And so looking at the number of initiations in the middle of the table, you can see that we expected 4 people perhaps in the month of October with 9 new initiations in November. What you can see on the far right column is that people are stopping PrEP. And so on the right, we're seeing the number of people actually on PrEP estimated per month based on continuation rates. So what we, as I said, we used the number of people on PrEP monthly as a proxy, just like done in treatment for the number of bottles of TE or TL that are necessary. And so we estimated that in order for Ghana to start PrEP in October 2020, 3,479 bottles would be needed to support those 1,418 people for the year. On the next slide, and so the aim was really to show the impact that PrEP implementation would have on stock levels of these same pills that are used for treatment. And so we needed to gather additional supply chain inputs. And so we looked at which ARVs are currently being used and included in the guideline for PrEP in country, which are both. And we looked at the current stock of PrEP ARVs in country and the shipments that were anticipated. On the next slide, what we've done is we have compiled all of that data together. And so here are the stock levels for TE and TL with demand for treatment only. And so what you can see is that by July 2021, if there were no additional shipments past October, there would be a shortage of ARVs for treatment. And so we only had shipment data through December. And so, this was a concern that we wanted to make sure it was addressed. On the next slide, what we've done is we have added in the expected need and demand for PrEP onto that forecast of ARVs for treatment. And combine that, and what you'll see is that we have started 0 people in July, August, and September. PrEP numbers start in October. And by July, again, there's a shortage. So what we're able to show here is that by starting PrEP, it does not have enough of an impact on the number of stock available in order to create an earlier stock out of ARVs. So then what we did is we were actually able to develop a number of other scenarios. On the next slide, we put together a forecast that would show the impact of stock levels if PrEP were started immediately. And so if PrEP were started in July, you can see that there are 5 initiations of PrEP, and then 12 initiations in August and 23 in September. And the result is, again, that the stock out comes in July if there are no further shipments of TE and TL. And so we were able to run a number of other forecasts, which included different scale-up scenarios, as well as inclusion of Global Fund targets in order to estimate to develop different scenarios of scale-up to meet a variety of targets. And so in the end, it was decided that Ghana was ready to start PrEP, and already there are more than 200 people who have started PrEP in Ghana. And so with that, we can move to see if there are any questions.
Great, thank you, Chris. Any questions about this presentation or any of the other presentations that we've heard today? Please feel free to add questions to the chat or to unmute yourself and discuss with the group. Any further reflections from Catherine or any of our other presenters on this topic?
Maybe just with respect to the quantification, I can just mention that we made a revision to the tool, which was initially we were just looking at kind of days of PrEP, but then as a result of feedback that we got from the Kenya team, actually, we incorporated this additional piece of information, which is the number of pills distributed per initiation visit and per continuation visit, so that you could actually have a number of pills that corresponds to the size of the bottle that you're providing. So that's just one change that we made to the tool in response to feedback that we got from users. So we're always looking for feedback from the users about usability or things that need to be changed to make the tool kind of more functional.
Great. Thanks, Catherine. And if anyone has thoughts or ideas about what they would like to see in the tool or any ideas that they have, please feel free to add them into the chat as well. But I think if there's no more questions, we can move forward. So we'd love to just, we have a survey here at the end of our session, and you'll see it pop up on your screen shortly, but just curious to see how you might plan to use PrEP. And you'll see options for target setting, costing, forecasting, tracking performance along the initiation cascade, other, or you do not plan to use PrEP. So we'd love to see how everyone here is thinking about using the tool. And we'll leave this open for a little bit.
Just going to leave it open for about 15 more seconds.
Mm-hmm. Seeing a lot of interest in using it for target setting and forecasting in particular.
Are you going to be able to show the results?
Oh, yes,
Yep.
We will be. And as soon as I think the
people are still trickling in, so
yeah, responses are still coming in, so we won't cut people off just yet. Okay, great. And everyone should be able to see that now. Okay. Well, why don't we go ahead and, or Catherine, I don't know if you have any thoughts that you wanted to share on the results of the poll, and if not, we can go ahead.
Well, I can just say that so far, most of the users have been using it for target setting. We'd like to see more use of some of the other modules like the initiation cascade and capacity. So I guess, you know, send us an email if you if you want to talk about any aspect of the tool. As I mentioned, we're developing an online version of it, so now is a really good time to give us feedback about usability or additional features that you're looking for.
Great. And Catherine, do you want to include in the chat maybe where people can email questions or thoughts about the tool?
Sure. We don't have like a dedicated email, so I'll just give my email address.
Okay, thanks. Great. Well, with that, we can start to close up today. Thank you all for joining us for this session. Our next session will be on January 21st in the new year, where we will be discussing healthcare provider training, different models of healthcare provider training, including virtual and in-person and hybrid models, as well as going through some different resources that already exist for healthcare provider training on PrEP. And then in February, we will be covering PrEP and intimate partner violence, including tools, resources, and processes to screen for and consider intimate partner violence and PrEP provision. So that is what is coming up, and we will be developing plans beyond February soon. And as a reminder, you can always visit PrEP Watch for the recordings to these webinars, for any of the materials from these webinars in both English and French. Oh, sorry, the January session is on the 20th, not the 21st. You can also find information about upcoming webinars on that page. And on that page, you can also sign up for the mailing list for this webinar series. So you will be receiving updates and the calendar invites for the Learning Network series through that, that email list. And finally, you will see already it has popped up. We had a question about how many people on these webinars are using the French translation. So you will see that pop up on your screen. If you could just respond to that survey before signing out, we would really appreciate it. It helps us get a sense of how many people are logging on to that service.
For those of us
So
that don't
please go
speak
ahead.
French, what does that survey question say?
It
Did you
says,
use the interpretation function today?
So we should put non if
Sorry,
we
go ahead.
didn't use the French.
You don't have to answer if you're using
We mostly
English.
want to know the yeses.
We're assuming if you didn't answer yes, then you're a no. But it is helpful to know for our planning purposes. Thank you, everybody. And it's great to see that people are using the French channel. So I'm not sure if, I guess everybody does see the results coming in, but there is a good number of people using French, so that's great.
All right. Well, thank you very much, everyone. And please feel free to log off now, but please do respond to the survey if you do use the French translation before you log off, because that's very helpful for us to understand. Thank you very much.